Alright, let's get this bonus session in. So now we're up to HIV in the infectious disease CK section. So, of course, big topic, huge topic, even back in step 1, where you had to know all the different medications, their side effects, all the different parts of the HIV virion, what they all did. So we're going to go back and revise that as well. So HIV, a retrovirus that targets and destroys CD4 positive T lymphocytes. Infection is characterized by a high rate of viral replication that leads to a progressive decline in CD4 positive count. The CD4 positive count indicates the degree of immunosuppression and guides therapy and prophylaxis and helps determine prognosis, right? So there were a list of infections that can occur depending on how low your CD4 count is, and once it's below 100, pretty much everything can infect the person. Viral load, how many copies of HIV virus you have, may predict the rate of disease progression, provides indications for treatment, and gauges response to the art. So like if you have an increasing viral load or a very high viral load, that means that you may have now developed resistance to some of the medications being used in the art. Acute HIV infection, which is acute infection, seroconversion, or acute retroviral syndrome, occurs days to weeks after exposure. The initial infection is often asymptomatic, which is extremely scary because then you don't know you have HIV. But patients may also present with mononucleosis-like or flu-like symptoms, which again don't really tell you you have HIV. So then at that point, people that get infected with HIV will never really know they have HIV until it becomes symptomatic AIDS, right? So that's why anyone that has unprotected sex or has a history of unprotected sex, or they tell you that they have a history of getting STIs, which are a hint that they have unprotected sex, those are all indications that you should probably order an HIV test for this person too. HIV infection can later present as night sweats, weight loss, thrush, recurrent infections, or opportunistic infections that otherwise healthy individuals wouldn't get. Complications are inversely correlated with CD4 plus count, says that as the CD4 count goes down, immunodeficiency goes up, and more infections can come and attack the person. So coming back to your step 1 microbiology section, if we jump right to pretty much the end of virology is the last part where they, the last thing they talk about is HIV. So right here we can see the revision of this retro RNA virus, right? So it's a diploid genome. It has 2 molecules of RNA in it. 2 molecules of RNA in it, each having its own reverse transcriptase, which allows it to make DNA from the RNA. The 3 structural genes, protein, code for different things. So you have your ENV, GAG, and POL, 3 different guys, right? So the ENV is the envelope guide. That's the one that's going to have your GP120 and GP41, as you can see here. 120 is for docking, and GP41 is the transmembrane glycoprotein. All right, they're both acquired through budding from the host plasma membrane. All right, so formed from cleavage of GP160 to form envelope glycoproteins. 120 is for attachment to host CD4 positive T cells, and 41 is for fusion and entry. So 40 fusion, right? 41 is for fusion and entry. You can see here now the next thing, GAG, that's your P24 and P17. They're the capsid and matrix proteins. P24 gives you the capsid. As you can see, that's the purple thing that's holding the RNA inside of it. And then 17 gives you the matrix. That's the orange. And so from inside to out, you have your RNA, then you have your capsid, which is purple, then you have your orange matrix. And then POL is just there for basically polymerase in a sense. So it gives you the reverse transcriptase, integrase, and protease. It's the main guy that gives you the enzymes, the 3 enzymes. Reverse transcriptase synthesizes double-stranded DNA from genomic RNA. This double-stranded DNA then integrates into the host genome. So this virus basically brings this RNA that will then make DNA and basically implement itself into you, right? Viruses are insane for being able to do this. They're literally altering your DNA, thereby being able to reproduce and make more, right? So now that it's part of your DNA, you're going to transcribe it and make new RNA, but when you transcribe that DNA into RNA, you're going to make the same RNA that was part of the virus itself. So basically, you'll be making more of the virus, right? Virus binds to CD4 as well as a co-receptor, either CCR5 on macrophages or CXCR4 on T cells. And then there's something here about the homozygosity of CCR5 and other things. So right now we just saw in the CK book how it attacks CD4 positive T cells, right? Now we're seeing exactly how. So it uses these receptors that are on your T cells and macrophages to go ahead and attack you. So CCR5 and CXCR4. All right. This information, I don't know if it would ever be a part of a CK question, but this is basically something that is under works and being used as a form of immunity. People who have a homozygous CCR5 mutation are actually immune to HIV, because if it can't attack your CD4 T cells, then your immune system will never go away and HIV will effectively do nothing to you. I think there was research done a long time ago where it was discovered that people who did have this mutation or did end up developing this mutation were mainly actually people who were sex workers, like prostitutes. So there's a lot of research going on about all of that stuff to see if there's any space for new discovery of any medication that can actually deliver this kind of a mutation and immunity to people. HIV diagnosis is also something very high yield. Of course, it's going to be even more high yield than CK, but this is actually very high yield back in step 1 also. So actually, let me move my own camera real quick so I'm not in the way. All right, here we go. So, presumptive diagnosis made with HIV 1 or 2 antigen or antibody immunoassays. So there are 2 different guides that we look for. These immunoassays detect viral P24 antigen, capsid protein, and immunoglobulins antibodies to HIV 1 or 2. So we look for this capsid. Very important thing to keep in mind, right? So that's the P24, that's the purple capsid protein here, inside the P17 matrix, all right? Very high sensitivity specificity. Viral load tests determine the amount of viral RNA in the plasma. High viral load associated with poor prognosis, obviously. Also use viral load to monitor the effect of drug therapy. Use HIV genotyping to determine appropriate therapy. AIDS is diagnosed once your CD4 count is less than 200, because normal is 500 to 1500. HIV positive with AIDS defining conditions, or CD4 positive percentage less than 14%. Right, so these are all things you look for AIDS diagnosis. Western blot tests are no longer recommended by the CDC for confirmatory testing. This is usually something that was tested on step 1, where they would talk about doing a Western blot, then doing the ELISA for basically specificity purposes and for ruling things in, right, to make sure that you didn't get a false positive. But in clinical practice, it's not really that big of a real thing. HIV 1 and 2 antigen antibody testing is not recommended in babies with suspected HIV due to maternally transferred antibodies. Use the HIV viral load instead. Right, and we're going to see in CK what you're supposed to do about this. Actually, I think it was right there. Yeah, right here. So if a pregnant HIV positive patient is not on ART at the time of delivery, she should be treated with zidovudine intrapartum. Infants should also receive zidovudine for 6 weeks after birth in hopes that you'll be able to stop the virus from replicating more and more and just get rid of it entirely from the baby. All right. But I mean, you know, you can hope for all the things you want to. Whether or not it'll work is a very hit or miss kind of thing. So this question usually presents with a woman that may not have gotten much intrapartum hospital visits. You know, she wasn't regularly coming in for her pregnancy checkups and stuff, and the pregnancy may have gone uncomplicated, but again, like, she may not have really ever seen a doctor. So maybe she was taking her folate and stuff because she knows about it, but she wasn't coming in for regular checkups. Maybe she doesn't have insurance, maybe whatever the other reasons could possibly be. Point is, at some point they'll also mention that upon testing, you found out that the mom is HIV positive and she's about to deliver pretty soon, maybe in like a month. So at that point, you right away start the mom on zidovudine. It's one of the medications you can actually take during pregnancy. And then you also give it to the infant for 6 weeks, a month and a half, possibly up to 2 months after being born. And you monitor the baby's HIV load, the viral load. So here in this table, they're just showing you, HIV 1-2 antibodies and P24 antigen combination immunoassay. If you do this immunoassay and it's negative for HIV-1 and HIV-2 antibodies and the P24 antigen, then the person is negative, and that's it, you're done, no HIV. If it turns out that the immunoassay is positive, then you need to figure out which one is positive, right? Is it just one of the two or both? Okay. If it turns out that both are negative, right, even though the immunoassay came out positive and both are coming out negative. Oh, wait. you did the HIV-1, HIV-2 antibody differentiation immunoassay, and you find out it's negative. So there's a difference here. First, you do the combination immunoassay to see if there's any positivity at all. You find out there is. Then you do the differentiation immunoassay to see which one it is. And you, for some reason, get negative results for both. Then you need to do the nucleic acid test for more specific testing, because maybe the differentiation immunoassay is having difficulty detecting it. Right? So that's all there is here in this diagram. It's something that you could get basic questions on, but it's not that complex of a topic to begin with. And then time course of untreated HIV infection. So the problem with this is that someone can have HIV, not know for the longest time, and that's depicted by the green clinical latency aspect, and then all of a sudden 5 years later, boom, the CD4 count goes below 400. And as you can see, as the red line is going down, the blue line is going up. The blue line is your HIV RNA viral load. And if the viral load gets really high, which is pretty much what's going to happen if you remain untreated, if the patient remains untreated, then it'll lead to death. Right? So this is really problematic. At the same time, what you can really see, the only cool thing, or the really indicative thing, is the yellow anti-envelope antibodies to the GP120. It reached a peak, and it stayed at that peak the entire time. It never goes away. Right, so that's something to keep in mind. That's a testable topic right there. Right, the anti-envelope antibody has reached a peak, and it never went away. So you see, the primary infection occurred. 1 month later, you started making the antibodies to the envelope, and that peaked by month number 2, and it never went away. So that's really important. That phase where this antibody started being formed, that's your viral dissemination and seeding of lymphoid organs phase right there. Right, acute HIV infection. Really problematic phase. I mean, you can't do anything at that time, and the worst part about all of this is that the person doesn't know they're HIV positive. This is why anytime anyone has unprotected sex, they should get tested as soon as they can, like within a week, within 2 weeks, and you keep getting tested accordingly based off of whatever your physician tells you is the best idea. And usually what will happen is you'll go in a week later or 2 weeks later, and the physician will tell you that you can't quite get tested right now. Come back after a month, ever since the day of your first time having unprotected sex, and then you could find this antibody, right? Otherwise, yeah, sure, you could go in earlier if possible. If they have the necessary devices, then they'll be able to check for the RNA viral count, which is already starting to increase right after the primary infection. So either way, you want to get tested as fast as you can, right? Because CD4 count has started declining right away with the infection, and then, of course, the infection was killing off T cells, so your CD4 count has started declining, and then it stays pretty stable for quite a while. As you can see, at some point, even though your viral load got really high, your viral load then comes back down, and things stay pretty latent. Nothing happens for quite a while, right? Up to 4 to 5 years, could even be 10 years. It really varies for everyone. Most patients who do not receive treatment eventually die of complications of HIV infection, right? So those are your 4 stages. This is the sketchy microimage, and you can find out more about this anytime. I mean, the story was really, really, really long. So let me see. Yeah, it's a pretty big story. But it did do the job. It did teach you a lot of the things you needed to know. But for the most part, the reason this image is so complex is because this majors HIV, but you need to know all the different treatments, all the different side effects, the different tests you need to do. As you can see, ELISA is mentioned here. There's a lot of things involved, that you get tested on, but not necessarily for CK, more so a step 1 thing. And then common diseases of HIV-positive adults, right? So as your CD4 count starts going below the minimum of normal, below 500, you start seeing things. So the first group of things would usually be the oral thrush, Candida albicans. That's a scrapable white plaque, pseudohyphae on microscopy. It's all Candida. And then if it gets worse, the more problematic thing they can have is the oral hairy leukoplakia, which looks pretty similar but is unscrapable on the lateral parts of the tongue. Right? That's Epstein-Barr virus, and that's really bad. Then they're pretty much at risk of even developing oral cancer. HPV, if they haven't gotten vaccinated, that can lead to its own set of issues. And then CD4 count under 200 and under 100 are the things that get tested very, very high yield. Right, like you can rest assured, if you can definitely see questions on PCP pneumonia, histoplasma, not so much of JC virus. HIV itself can, by the way, cause dementia at this point. This is a really nice one to watch out for. Most people don't tend to think of this one at all. All right. And then here you can see things that would get tested. I would say definitely Candida esophagitis. CMV issues are a big one here. B-cell lymphoma, toxoplasma gondii causing brain abscesses with multiple ring-enhancing lesions. Big giveaway for someone having a really, really low CD4 count, right, under 100. And yeah, the Cryptococcus meningitis is also a big one. So of course, at some point you might have seen questions on all of these topics, and it definitely helps to be able to identify that anyone getting one of these infections must be immunocompromised. That's a very important thing to keep in mind, because these infections don't really occur to people who have a high enough CD4 count, right? Like histoplasma causing all of these systemic symptoms of diarrhea, fatigue, cough. Not really something you would expect in a healthy, normal individual that doesn't have HIV. Right, so that's kind of what they're showing you here. They also have this note: CMV retinitis is painless with fluffy granular hemorrhages. In contrast, HSV or varicella zoster virus can cause a severe, painful inflammation that can lead to acute retinal necrosis syndrome with widespread pale and necrotic retinas. Right, so which bug is causing the retinitis? Again, like you're going to get questions where you first have to identify that someone has HIV, understand that they have possibly AIDS, depending on their viral count and CD4 levels, and then figure out what's causing the infection. And a lot of these viruses are very similar. I mean, all the herpes viridae are generally very similar. So you have to figure out based off of their symptomatic differences. Here you see oral thrush. So see, oral thrush is more so in the central area, whereas hairy oral leukoplakia would be on the lateral parts of the tongue. So right here they mentioned ELISA test, right? High sensitivity, moderate specificity. You can use this to rule out, because it's very sensitive, the snout mnemonic, rule out HIV, detects anti-HIV antibodies in the bloodstream, can take up to 6 months to appear after exposure. Right? Anti-HIV antibodies take a very long time to appear after the initial infection. So you can see they're talking about this kind of antibody right here. Right? So in this diagram, it started appearing after a month, but it can take even longer. Right? So anti-HIV antibody. And then they have the Western blot, which has very low sensitivity, but it's very specific. So you're supposed to use that as a confirmatory test. Right, so once you do the ELISA test and it actually comes back positive, to make sure it is actually detecting HIV, you do the Western blot, right? Because the ELISA test is not very specific. Rapid HIV tests are now available. Baseline evaluation should include HIV RNA PCR to do the viral load, CD4 positive cell count, chest x-ray, PPD skin test, or interferon gamma release assay, IGRA. You can also do a pap smear, mental status exam, because HIV can cause dementia. You can do the VDRL RPR to check for other things, right? That's a venereal disease test. You're supposed to use this for syphilis mainly, right? And serologies for CMV, viral hepatitis, toxoplasmosis, and VZV. You need to check for everything, especially after you actually have seen that the person has HIV. You want to make sure they don't have any of the opportunistic infections already. Evaluation for acute retroviral syndrome should include HIV RNA PCR. ELISA may be negative. Now, treatment is pretty much forever because you can't cure HIV, right? So treatment is lifelong antiretroviral therapy for all HIV-infected patients, regardless of CD4 count or the associated symptoms illnesses, especially benefiting those with CD4 counts less than 500. It is important to counsel patients about medication adherence, benefits, and risks, and this is going to be your ethical topic, right? A patient might come in telling you that, hey man, I haven't had any issues with my HIV in like 4 to 5 months now. I don't think I want to take any more of these medications. Maybe they don't have insurance and they'll be like, it's too expensive for them. Wide array of topics they can use, right? Point is, you have to let them know that if they stop taking their medication, they're probably going to end up dying. and that all the complications they've been able to dodge so far are going to come back. So you have to educate your patient on the fact that they have to take these medications forever. They can't stop just because they're doing well now. They're doing well now because they didn't stop. Right? It goes the other way. Initial regimen should generally consist of 2 nucleoside-nucleotide reverse transcriptase inhibitors plus 1 integrase inhibitor, which can be substituted with a non-nucleoside reverse transcriptase inhibitor as well, or a protease inhibitor. Goal of therapy is complete viral suppression. After therapy is started, CD4 positive count and viral load should be monitored monthly until suppression is achieved, and every 4 to 6 months afterward. HIV genotype should be obtained before initiation of therapy and when resistance is suspected. As such, testing can provide mutation information and identify resistance to specific antiretrovirals. HIV-1 and HIV-2 are affected differently by different medications, and we're going to see that. In the setting of percutaneous injury, mucous membrane exposure, or non-intact skin exposure with an HIV-positive source, begin ART as soon as possible. So that's going to be for like nurses or doctors that might be working somewhere where they get exposure to HIV patients. Right, with the 2-drug regimen or an expanded regimen of 3 or more drugs for 4 weeks, depending on the severity of the source of infection. Now, there's going to be a couple of big topics regarding HIV on CK that are huge coming from UWorld, right? Vaccinations for adults with HIV. This is a table with prophylaxis for HIV-related opportunistic infection, which also includes whether taking vaccines or taking a prophylactic medication before you get the infection. You're going to need to know HIV management during pregnancy, as we just spoke a while ago, to start with the Zidovudine, right? HIV in infancy. We're going to see some of these practice questions pretty soon, including some of the commonly tested diseases that cause very vague symptoms in HIV patients, right, if they get infected. So let's dive right into that. First thing we have here is this thing, which is related to the percutaneous injury portion right there. So occupational HIV post-exposure prophylaxis, right? So you have your high-risk contact where prophylaxis is recommended. So high-risk contact means that you had contact with someone who has really bad viral load, right? Exposure of mucous membrane, non-intact skin, or percutaneous exposure. Exposure to blood, semen, vaginal secretions, or any body fluid, etc. You need to start prophylactic medications with ART right away on that person. A low-risk contact doesn't really need prophylaxis, right? So if you have exposure to urine, feces, nasal secretions, saliva, sweat, tears, no visible blood, there's very, very, very remote chance that the person is going to get HIV. But that remote chance is scary enough, right? So for test purposes, prophylaxis is not recommended, but realistically, if that was you, you would probably start taking prophylactic medication. Low risk doesn't mean no risk, so it's still scary. Initiate urgently, preferably in the first few hours, and continue for the whole month. Regimen includes 3 or more drugs, 2 nucleoside-nucleotide reverse transcriptase inhibitors, plus an integrase or protease inhibitor, or an NNRTI. All of the medications which we will learn about all the way back here. Right, so HIV therapy. Now, looking here, you have your NRTIs, which are all named weirdly and even have very weird 3-letter acronym associations. All ARTs are active against HIV-1 and HIV-2 with the exception of non-nucleoside reverse transcriptase inhibitors, right? So if we look at them, those are these 3 guys, delavirdine, efavirenz, and nevirapine. Right? They're the 3 medications that have vir in the middle of their name. Right, so they're different from these other guys who have vir at the end of their name, so that's when you know you're talking about a non-nucleotide reverse transcriptase inhibitor. These guys block HIV-1 reverse transcriptase, right, through a specific binding site that is not present in HIV-2. This class of drugs will not be effective against HIV-2 due to the Y188L polymorphism. This was taught in a UWorld question. Do you need to know it? I'm not sure. Right, but there's something that doesn't belong on HIV-2, which is why the NNRTIs don't work against HIV-2. All right. So these medications, generally speaking, all of them are virus killers. So they inhibit nucleotide binding to reverse transcriptase and terminate the DNA chain. but they can also end up affecting your own DNA division, so you can end up getting bone marrow suppression, right? You could also end up having peripheral neuropathy, lactic acidosis, anemia, and pancreatitis. Most importantly, the Duvidine, which is a very high-yield medication, can cause anemia, and didanosine, rarely tested medication, this is the one that causes pancreatitis, right? So you could get a patient who might have HIV, started treatment with some new medications, and then has pancreatitis. The answer will be to discontinue and switch didanosine with something else, right? And then the protease inhibitors, they're all Navir. All of them are Navir medications. They all have their own set of different weird side effects that you could get questions on. And integrase inhibitors are all going to have Tegra in the name, which just elevate creatine kinase. And so this is just the general revision of all the medications. You should definitely make sure you know them pretty well. You had to know them for step 1. You should know them here as well. So now let's look at some of the practice questions that are here. First one, 35-year-old man comes to the office due to a week of pain with swallowing, a substernal burning sensation. Right? So pain with swallowing is a big one. That's a dinophagia. And substernal burning sensation. So basically heartburn. The patient was diagnosed with HIV 2 years ago. Oh, sorry, not HIV 2, just HIV. And he was diagnosed 2 years ago. He was previously non-compliant with treatment, but recently started taking antiretroviral therapy and TMP-SMX. Okay. CD4 count a month ago was 46. Oh, no wonder. So that's why he had to start taking this prophylactic medication, because now he's at the risk of pretty much getting any kind of infection. He doesn't have any CD4 counts. Vitals are pretty good. Exam of the oral cavity shows white plaques on the buccal mucosa and palate that are easily removable with the tongue scrapers. So if they are removable, that's basically just candida. The lungs are clear to auscultation. Abdomen is soft and non-tender. What is the appropriate next step in management of this patient's substernal chest pain? So the answer was oral fluconazole. 60% of people picked it, but 30% of people, for some reason, I'm not sure if they haven't seen this in step 1 or they were just confused, or I'm not sure. I don't really get why they would pick this. 30% of people chose endoscopy with biopsy, cytology, and culture. But why? You know it's candida. Like, you know for sure it's candida. So why would you do a biopsy? Right? Why would you do an endoscopy and take a biopsy? It makes no sense. This patient with AIDS has pain with swallowing, substernal burning, and oral thrush, indicating candida esophagitis. Infectious esophagitis is common in patients with advanced CD4 less than 100, as we just saw. Right? We just saw that when we were looking at things that can occur. Right? So it's basically coming from this page. We know that candida can be the one that causes oral thrush, and if your CD4 count gets even lower, you can get candida esophagitis, which was what's causing his pain with swallowing, right? And substernal chest pain. Patients who do not. So wait, where was it? Although all generally cause progressive pain with swallowing and substernal burning, the presence of concurrent oral thrush usually indicates C. albicans infection and should prompt empiric treatment with oral fluconazole. Right? Because infectious esophagitis can be caused by other things as well, like HSV and CMV, but he has the buccal mucosa oral thrush, so it's most likely the same candida that's causing his esophagitis. Patients who do not respond to the empiric treatment or do not have oral thrush at presentation often require further evaluation with upper endoscopy and biopsy to identify alternate causes. So that's where the second answer choice would be correct. HSV esophagitis is usually marked by endoscopic evidence of small, round, oval, volcano-like esophageal eruptions. You can also call them punched-out ulcers, and multinucleated giant cells with intranuclear inclusions on biopsy. And you could just give them acyclovir or valacyclovir for treatment. CMV is treated with ganciclovir. Right? This thing causes linear ulcers in the distal esophagus, and biopsy evidence of intracytoplasmic and intranuclear inclusions. Both of these are herpes viridae, so they both have the intranuclear inclusions. Neither HSV nor CMV esophagitis are treated empirically, though. You would have to do the biopsy at that point. Right, so that's what this diagram here is kind of helping you understand. Whether or not you see the white plaques is the main thing. A 43-year-old man comes to the clinic due to fever, night sweats, fatigue, and progressive skin lesions. Very vague, right? He says the skin lesions started as small reddish-purple papules that gradually enlarged to large nodules. He has a history of HIV, so now you start thinking, oh, that's why this vague description is being given. this is not so vague anymore. Now it must be describing something that occurs in HIV patients, and by looking at the way they're describing it, it should remind you of Bartonella, right? That this is probably the bacillary angiomatosis with tomato-type looking lesions all over the skin. He has HIV and he must want to die because he doesn't take his ART or prophylactic antimicrobials. So at this point, why even come to the clinic? Like, you clearly don't want to take your medications. Stop wasting time. Stop wasting resources. It's quite a irking topic. His last CD4 count 3 months ago was 50. He has been hospitalized in the past for PCP pneumonia. He's homeless and primarily lives outdoors, but sometimes stays in shelters. Temperature is a little high, but everything else is generally fine. He is cachectic because he's dying. White plaques are present on his palate. Hepatosplenomegaly is present. Skin exam shows several purple pedunculated lesions on the face and extremities that are friable and bleed easily with palpation. Bacillary angiomatosis. CT scan of the abdomen reveals hypodense liver lesions that enhance with IV contrast. What is the most likely cause of his current systemic illness? So the liver thing might be something else, but his current illness with the skin thing and all the other problems he's having are mainly related to Bartonella. So we don't really need to get thrown off by this liver lesions thing. It could be related to Bartonella. It could be completely something else. Stay on point though. So far the question was all about Bartonella, right? So that's it. The answer was Bartonella hense, 50%. 25% of people chose Mycobacterium avium complex and 10% chose CMV. Now, CMV doesn't make any sense whatsoever to me. Although I can see where Mycobacterium, the MAC, where that came from. Bartonella are gram-negative intracellular bacteria that typically establish infection through cutaneous penetration after a cat scratch or body head lice bite. Right? It's a zoonotic bacteria. The organism causes a local dermal infection, spreads to the vascular endothelium, and then attacks red blood cells. Major manifestations of infection are therefore mostly cutaneous, lymphatic, and endovascular. BAC is a Bartonella infection, right? Bacillary angiomatosis is a Bartonella infection seen primarily in patients with HIV, CD4 count less than 100, because CD4 mediated immune response is crucial for controlling and elimination of the organism. Symptoms feature vascular cutaneous lesions that often begin as small reddish purple papules and evolve into friable pedunculated or nodular lesions. Constitutional symptoms are typically present and organ involvement may occur. Diagnosis is made by tissue biopsy with histopathology and microscopic identification of the organism. Treatment requires antibiotics like doxycycline or erythromycin and the initiation of antiretroviral therapy. Mycobacterium avium complex and CMV are common infections in patients with a low CD4 count, but they don't cause angiomatous skin lesions. In fact, the only reason that Mycobacterium avium complex thing even comes to mind for most people is because they are thinking of, let me see if I could find it. Yeah, right here. So, intracellulares. Where do you go? Oh, right here, avium, intracellular, right? That's the one? Yeah, avium. So the avium thing causes disseminated non-TB disease and AIDS, often resistant to multiple drugs, and it can actually cause symptoms of even similar to marinum, like skin infection like that. And of course you don't want to confuse this with what we're looking at right now. So it was like slightly relevant, but not really. Bartonella and Hensley made a much better explanation of the patient scenario in this question, and it was definitely bacillary angiomatosis, so it wasn't that confusing, really. Alright, now moving on, we have the topic of using TMP-SMX, right? So here, 54-year-old man comes to the office due to 2 weeks of progressive fever, exertional dyspnea, non-productive cough. He has a history of HIV, but does not comply with the heart, which is going to be the case for most questions about HIV on your step, and hopefully it won't be a real scenario in the real world, but again, it can happen. Temperature is very high, right? Blood pressure is fine, pulse is fine, everything else is looking alright. Pulse oximetry is low. Oxygen saturation increases to 92% when you use the 100% non-rebreather mask. They do his labs, and his hemoglobin is a little low, right? Platelets are also low, so 150 to 400K. And he's got 8K leukocytes. Then they do his arterial blood gas, which is a giveaway for what must be happening, right? So you can see it's alkaline, right? CD4 count is 170, LDH is 480, a lot of cell death is happening. Chest x-ray reveals diffuse bilateral interstitial infiltrates. What is the most appropriate next step in his management? And people were pretty confused, so there were two answer choices that everyone picked. First set was TMP-SMX and corticosteroids. 50% picked it, that was the correct answer. But 35% of people chose TMP-SMX only. So just give trimethoprim. So how do you pick between one over the other? This patient with HIV has subacute dyspnea, fever, dry cough, elevated LDH, and diffuse bilateral pulmonary infiltrates, raising suspicion for PCP. This is pneumocystis jirovecii pneumonia. Most cases arise in those with untreated AIDS and the CD4 count less than 200. Manifestations are generally indolent and include exertional dyspnea, dry cough, and fever. Very TB type of progression. Lab evaluation frequently reveals elevated LDH, and chest x-ray usually shows bilateral infiltrates. Diagnosis is confirmed when you actually identify it on bronchoalveolar lavage. Treatment is with TMP. It will cure the problem. Since P. jirovecii proliferates within the alveoli and triggers a strong inflammatory response, patients with PCP often have significant hypoxia and a large alveolar arterial oxygen gradient, a large AA gradient. Hypoxia often worsens with the initiation of antimicrobial treatment due to the release of pro-inflammatory intracellular macromolecules during the lysis of the organism. When you kill the organism, more inflammation is going to occur. Very similar to your Hersheimer reaction. When you're killing things off, you're just going to have more inflammation. So, concomitant corticosteroids are generally administered to those with severe PCP to reduce the inflammatory response. Many people that died of COVID-19 actually died getting treatment because their own body responded too intensely to the viral infection itself. So generally speaking, corticosteroids are looking like, of course we all know corticosteroids seem, if they didn't have the side effects they do, they seem like the godforsaken best medication out there because they can help you with so many things. Right? Very anti-inflammatory, very amazing thing, but the side effects it has are a heavy price to pay. For this person, you have to give the corticosteroids because if you're treating something like this, you don't want the bacterial death to cause more inflammation. So that's all you really need to understand here. Otherwise, everyone generally did, it looks like they caught what was happening. They got that it was pneumocystis. This question was just here to teach you to add corticosteroids. Right? We've seen this as we've been going along so far. We've seen this in other case scenarios where there are a few other medications to add, but no one really talks about them. So very important to keep in mind, especially when you do questions like this, what else are you supposed to add to the regimen? And, in this table here, they list it out for you. Right. Next one here, 26-year-old woman comes to the emergency department again due to a week of fever, chills, dyspnea, non-productive cough, and fatigue. No chest pain or hematitis. She has a history of lupus and was diagnosed with lupus nephritis by renal biopsy 4 months ago. Okay. She started taking cyclophosphamide and prednisone, 40 milligrams daily, which has stabilized her renal function. But cyclophosphamide is a scary medication where you're supposed to give mesna too, otherwise it can cause bladder cancer. So I don't know why they're not saying that, but always a good thing for you to revise. She doesn't drink or anything. Temperature is high. Blood pressure is a little high. But that makes sense for her blood pressure to be a little high because she has lupus nephritis. Pulse is fast and respiratory rate 24. Pulse oximetry is 86%, which is under the 96 that we hope for. You definitely don't want anything under 90. She's using accessory muscles to breathe. No jugular venous distension is present, so it's not that the heart is the problem. Cardiopulmonary exam shows bilateral crackles and normal heart sounds. There's trace peripheral edema in her lower extremities, so bilateral crackles usually mean some kind of pneumonia. Labs, arterial blood gas, so she has alkalosis. LDH is high. Okay, so that should give away a little bit of the stuff. We actually saw that here too, right? LDH is high in both of them. Chest x-ray reveals bilateral interstitial infiltrates. What's the most likely cause of her condition? Nowhere in the question did they really mention she has HIV, but they didn't need to, right? Because it was pretty clear from the LDH and everything else that's happening to her that the most likely cause is probably pneumocystis pneumonia. Very similar presentation in both of these questions. They both have the elevated LDH, they both have the low oxygen saturation, and they both have the bilateral interstitial infiltrates, right? One other thing they both have is immunosuppression. The first person actually has HIV. This person is taking prednisone, which causes immunosuppression. PCP is an opportunistic infection that occurs almost exclusively in patients with severe deficits in cell-mediated immunity. In most cases arise in those with untreated AIDS. It can also arise in patients on chronic glucocorticoid therapy, particularly when combined with other immunosuppressive medications like cyclophosphamide. So that's all this question was really about. Not so insane. Over here, just guideline stuff, right? So current guidelines recommend that all pregnant women with HIV begin taking combination ART as soon as possible, regardless of HIV RNA viral load or their CD4 count. This is to minimize maternal risk of HIV infection and reduce perinatal transmission. Drug resistance testing is performed prior to treatment, but treatment is begun immediately and modified according to results later. If an infant of parents with unknown medical history and poor medical records presents with chronic diarrhea, lymphadenopathy, failure to thrive, and infections with opportunistic infection, such as PCP, Candida, you should suspect HIV infection. Okay, and just immediately start combination antiretroviral therapy, hardcore, high doses, and then monitor the baby. All right. So that's basically it for all of that. Other than that, make sure you revise this table, go through these bugs, make sure you remember what other things they cause, and take your time memorizing this. This takes time to memorize. This definitely takes time to memorize. So this would be stuff you would memorize on another day, the vaccinations, where you'll study this in conjunction to, I don't even know where in CK they actually talk about vaccinations. I forget. Was it? Yeah, it was in epidemiology with the screening recommendations. So you want to make sure you revise this with the revision of general vaccinations as well, because you will get a question on vaccinations, and it's going to ask you like, oh, what vaccine should you give this person? What's the next best step in their management? Or what recommendation will be the best recommendation to give this person? And you have to make sure that you think of these. So, again, revision and revisiting these topics is the best thing you can do to make sure you grab it. All right. And then in the next video, we'll go on to opportunistic infections, which is definitely relevant to HIV as well as any other case scenario of immunosuppression.